Save, share. All right. Blood. So, leukemias. Leukemias are essentially dysfunctional cell lineages. Either they're going to be a root of a myeloid, and so in here something's going to be dysfunctional, or the root lymphoid. There's actually 4 types of leukemia. We don't get into detail really with that, but there's AML, which is acute myeloid leukemia, ALL, which acute lymphoid leukemia, CML, chronic myeloid leukemia, CLL, which is chronic lymphoid leukemia. They kind of range like in their age groups. Like AML is usually young children. And what's neat with that one is vitamin A causes cell differentiation. There's actually a subtype, it's called the M3 subtype of AML, that the cure for it is you give them high dose vitamin A. You literally give them like retinol and they're cured. I had a friend in high school that had it, and he started high school with us I think he started in 10th grade, 9th grade, mid 9th grade. Um, we actually became really good friends, and he was in remission at that point. He had just gone into remission. Until this day, he's healthy. And he had that AML subtype. They just gave him high dose vitamin A, cured. But he was quite the character. We were really bad. We were the school clowns, the two of us. Not class clowns, school clowns. It was a small little Southern Baptist high school we went to, so we were just buffoons between the two of us. Okay, like pushing Coke machines behind the teacher's door so she couldn't leave the classroom, stuff like that. Just silliness. Okay. Anywho, ALL. You tend to see in the to say 15 to 40-year-old, somewhere in there, a little more aggressive, typically can be treated. CML, which is the next one, that's more aggressive. You tend to see in your 40 to 60-year-olds. My uncle passed away not too long ago from CML. CML tends to be pretty aggressive. It has a correlation with benzene rings. Benzene rings are found in fuel. So back in the day, when, especially up north, where you had, a lot of people like at the gas stations, they fill the gas for you. They have the gas attendants. They were popping CML left and right. So it was my dad's brother out in Australia. He was a taxi driver. And so they think because of that, the fumes driving around in the taxi all day was the correlation there. And then CLL, typically you see it in the 60-year-old and above. It's chronic. They'll go 15, 20 years with it before they die. A friend's dad had it, and he had it for years. He passed away a few years back, but he was much older when he passed, and so it's more long term. Okay, so the problem is when these cells are non-functional, they're mutated, they're non-functional, they start to replicate like wildfire. So you see big numbers because they're not working. So the body just keeps on making more and more, trying to get it to function. So we see it randomly. They'll get random infections, bruising, stuff like that. Just depends on what lineage they have. And that's how we tend to identify it. One of my wife's coworkers during the pandemic collapsed in the hospital. Fellow pharmacist collapsed in the hospital. They go to check it out. She has leukemia. I forget which one she has. It was tough during the pandemic. No one. She has a young kid, husband. They couldn't come see her. She was just stuck sitting in the hospital. I think it was like 6 months, 8 months, something like that. No visitors allowed. So the hospital started doing they get the iPad and they can communicate that way for the patients, but it's tough. She did a transplant. They wouldn't allow anyone in. There's no immune system. So when you take out these white blood cells, that's it. Immunity is gone. So you become kind of like an HIV patient, if you will. That's the same concern with HIV patients. There's no immunity. So any common cold, any little bacteria they get exposed to or virus can kill them. So when you talk about bone marrow transplant, that department, you can't just walk in willy-nilly. They're in negative pressure rooms, special rooms, you got to garb up when you go see them, stuff like that to protect the patients. Right? So it's just concern of exposure. Okay. She did a transplant. It didn't take. She rejected. So we try and match people whenever we do transplants to markers on their cells and try and get it as close of a match as we can. That being said, anytime you do a transplant and it's living tissue, the body can still identify it as foreign and tries to attack it and reject it. So she rejected. She did another transplant from her father. Her father was a match. Like, that's pretty darn close. Like, when you think about it, they're about 50% the same genetics. Our genes mutate when we talk about meiosis, when we make gametes, we do mutate them. They are different. We pass them on, but they're pretty darn close. She has graft first host disease. Graft first host disease is now these new white blood cells that have been implanted, these stem cells implanted into her, are seeing her body as foreign. They have attacked her lungs and she has lung failure. There's not much to do. It's not graft versus host disease is not a promising future. Really, the only solution there is to irradiate her again and try and transplant her again, and most likely not going to happen. So rough situation. She's younger. You never know when it's going to hit. So that's why, like, stuff like this, it's always important to stress, especially with, like, you guys and patients and stuff. Physicals. Your yearly physical is huge. People don't think about it, but when you do blood work, you start to see anomalies. And it also gives us a baseline, right? You come in later and we have a baseline to go again. So yearly physicals are important. Preventative medicine is something we need to push here in the US. That is where we are deficient compared to other countries. Other countries' medicine is not better than ours. Ours is superior when it comes down to it. But what we lack in is preventative medicine. If people would go and get checked out, we would catch a lot of diseases early and we could deal with it early. When you come in and the patient's swirling the drain, it's hard to bring them back, right? So preventative diseases or preventative measures is important, like educating patients on not smoking. Well, if you do that, you reduce cancer numbers. We're not chasing cancer now, things like that. So it's important. All right. All right. So you guys can go through those terms. We've talked about them. Make sure you know them. They could throw it in a question and you don't want to get lost in the question because you couldn't identify a term, right? You may know the topic, but the term throws you off. So make sure you are familiar with the vocabulary. All right. Platelets, they are not cells. They are fragments of cells. They come from megakaryocytes. So the megakaryocyte fragments, and that creates the platelets. They are functional. They do secrete things. They communicate. And their primary purpose is blood clotting. These guys are constantly working in you, not just when you have a bleed. Right now, while you're sitting there, they are creating clots that are necessary. Where they're creating clots is between your vessel cells, the endothelium, these little holes. We don't want them wide open. If they're wide open, blood pressure will tank. Okay, we'll bleed out easily. You'll third space, stuff like that. So dysfunctional platelets are a big deal. So as far as platelets, you'll see anywhere from, I think your book says 200,000 to 400,000 is normal. I've seen 150,000 is normal. Okay. As far as the chemicals that are in them that we talk about, ADP, adenosine diphosphate, we've learned about ATP. It's just missing a phosphate group. It has functionality. So he creates, so when platelets release it, he attracts more platelets to him. And he causes the platelets to release other things that are in them. So what does he release? Serotonin. That's a vasoconstrictor. Thromboxane A2, vasoconstriction and aggregation, platelets sticking to each other. Okay. Plavix, you may have heard of the drug Plavix, commonly used for patients that have like stents, for example. So when we talk about in the heart, there are arteries that are feeding the heart muscle, not coming out of the heart to the body, but they're coming off the vessels and going back to the heart to feed the muscle itself. That's where heart attacks happen. That's where the plaques build up at. Plavix inhibits the ability for this attraction of platelets. So when they put in a stent is a tube, and they talk about like drug-eluting stents. Typically, they have something on there to stop aggregation, to stop that sticking. And then they even put the patients on Plavix typically. So my dad had a stent back in like 08, 09. He had a stent put in. And then he was on Plavix for a long time. His doctor decided to pull him off because now the guidelines say they just need to be on it for like 3 months or so. And then pulled him off. And then my dad was on a plane and he had a TIA. They were going to Jamaica. I was in Mexico. My wife was going with them. My brother-in-law and stuff, they're all going there. I was in Mexico for a buddy's bachelor. And I get a call that said, "We think your dad had a stroke." A text. And I'm trying to reach everyone. You can't reach anyone. No one's got their phones on. Try to see what's going on. So on the plane, what happened is he had a momentary clot. These platelets aggregated for some reason. So we see this a lot when patients sit on planes. Why? Why do we see it a lot when they sit on planes? They're not moving. When we don't move and there isn't circulation, especially in the legs, the blood can start to clot. You see this a lot, long car rides, long train rides, but planes are the most common when you talk about long distance, people aren't moving. And so there's stagnation of blood. The blood begins to clot. In women, they are at higher risk. Estrogen increases. I think Natalie, if you try and annotate, it's going to annotate for everyone. Okay, yeah, just had to. Oh yeah, no, you're good. So women are at higher risk because of estrogen. Estrogen increases clotting factors, and then when you mix in smoking, smoking is going to increase that. So that's always a big, huge concern when a woman is on oral contraception, and she's a smoker. It's a big, huge concern. Uh, Moving your legs is important. So they'll tell you, like when you're sitting on a plane, do like calf raises. Just point your toes up, do that. And the muscle milking, and we'll talk about that, helps move the blood around. When patients are having surgery, we put these special inflatable boots on them, and it'll squeeze and release to help move the blood around. It doesn't take much. Aspirin, aspirin and Motrin, no, yeah, aspirin and Motrin are antiprostaglandins. They inhibit thromboxane A2. So that's why, when people are having heart attacks, they will tell you crush aspirin, let them chew it and take it. And that can help prevent the heart attack from being much worse. So when my dad was having his TIA, the reason we know it's a TIA, suddenly his speech became slurred, his face kind of drooped and jerked, and like his arm pulled. These are all signs of a TIA. A TIA is a transient ischemic attack. It's kind of a stroke that happens temporarily, and then the clot blows through. So there was a nurse on the flight. My brother-in-law is a surgeon. He's with them. And the nurse was like, "I have aspirin." Gave him aspirin. He chewed it up. It cleared. So after that, he went back on Plavix. Okay. Plavix it's a good drug, other than the downside is like when he shaves, for example, he just won't stop bleeding. If he nicks himself, he won't stop bleeding. That's the concern. So when patients are on these drugs, the risk of bleed increases. They trip and fall, they could have a brain bleed. So typically we now use, I'm going to blank on it. It'll come to me. So they advertise it on TV all the time. Yeah, well, it'll come to me. Maybe someone will chat. If someone knows what I'm thinking of in the chat. Oh, sorry. I forgot to bring up the chat. Yes, Bia. Yes, to answer your question. In lab. Yes, I got you. All right. There's Leslie. Okay. If anyone can think of the drug they always advertise on TV for like preventing blood clots. And they're like, you don't have to go to the doctor for blood work all the time. Man, I can't think of it. What is it? Eva? I cannot think of it right now. It's like the most predominant that we give. Anyhow, um, it's gonna bug me. Now I gotta find it. Okay. Let's see. Anti. So that brings up a good conversation. We don't give blood thinners. Blood thinners is not a proper term. We give anticoagulants. Anticoagulant is stopping the clotting. Coumadin. We'll think of it. Anywho, it's stopping this process that we're talking about. It's stopping the platelets or thrombocytes from functioning, or something in the cascade that causes true blood clotting that we'll talk about. Okay, so people can have dysfunctional platelets if they're making too many, not too many. Too many, it's because they're not functioning properly. It's the same process as leukemia. So we can see when that happens, they're going to bleed out easily. They're going to bruise easily because they don't have clotting factors like they should. Thrombocytopenia, that is too low. So a component that helps make them is deficient, or we're consuming them. So they're like having clots, stuff like that. In that situation, they also will consume them. Infections, technically, yeah. Okay. Chemotherapy, because we're killing off the stem cells that make the megakaryocyte. All right. Your blood vessels, simple squamous, thin. We have to allow for diffusion. That being said, they are lined basically with Teflon. That's prostacyclin. Prostacyclin is like a Teflon. We need that coating. If that coating is damaged, platelets will stick to it. That is a problem. It's good when you talk about like a wound. It's bad when you talk about like internally. So what's going to damage it internally? What's going to damage your blood vessels? We learned about it. What's bad for you to eat because it damages your blood vessels? Huh? Fat, cholesterol, specifically LDL. LDL damages the blood vessels. When they become damaged, macrophages migrate in. They create these fatty streaks, plaques, that starts to stick out, damages the prostacyclin, platelets start to stick. We slowly form that clot in our blood vessels. Happens very early on. Okay, so if it's damaged, things stick. What sticks? Platelets. Why are they sticking? Because collagen is exposed. That means there's a wound. So we start to stick. They release that ADP, they release serotonin, thromboxane A2, and we form what's called the temporary plug. It's temporary. It doesn't really stick really well. It can rupture again very easily. It's the same logic of like when you get a little wound, it'll stop bleeding pretty quickly, but if you barely agitate it, it'll bleed again. That's the plug. Oops. So how do we stop it? Vasoconstriction. Why do we vasoconstrict? Serotonin. Aggregation, the sticking of platelets to each other, and then coagulation. We're going to talk about that specifically. When you guys watch the videos online, it cuts short for this section. I will cover it. Don't panic. It does cut short. There was something incorrect in it, and so they cut it short. That's my understanding. Okay, Dr. Schultz's video. So just heads up on that. Don't panic. All right. So vasoconstriction. We need to tighten down the flow. We don't want blood just freely flowing out of there. There's that serotonin. Next, the platelet plug. Platelets will stick to the collagen. Platelets will release ADP, serotonin, thromboxane A2. More platelets will come, more platelets will stick. Now we talk about coagulation. Floating in your blood is fibrinogen. What's that gen on the end mean? Huh? Proenzyme. It's not active. We will activate it into fibrin. It will create this mesh, this stickiness. Think like a web, like spider web, and it'll just really stick everything in there. And then it'll tighten itself. That's the clot retraction. And we'll push out serum. Serum is that clear fluid. If you've ever had a wound like on your skin, and you peel the scab and that clear yellowish color kind of comes out, that's serum. All it is, it's interstitial fluid. All that is plasma minus albumin, minus cells. It's really like the true root of the fluid of plasma. That's all that is. Okay? So platelet adhesion is due to prostacyclin. So that we give those antiprostacyclins to stop it. Okay? Sorry, prostaglandin. Prostacyclin is what stops it from sticking. My apologies. Prostacyclin is like Teflon. You know, the coating on your skillets? That's what stops it from sticking. If you damage that coating because you use like metal utensils on there, what happens? Your food starts to stick. It's the same concept in your blood vessels. You damage your blood vessels, the prostacyclin's gone, collagen is exposed, sticking of platelets. Right? So, why do we release the platelet chemicals? Because platelets are adhering to collagen. So if they adhere to collagen, we start to release these chemicals. So we can see a couple things released here. We talked about ADP, thromboxane A2, and serotonin. So these are referred to as chemokines. Chemokines, when you talk about ADP and thromboxane A2 should be considered chemokines. They're attractants. They're going to help attract neutrophils, macrophages, and the macrophages in themselves, the neutrophils in themselves will release chemokines and attract more. This can be the pus in a wound. Pus is really just white blood cells or bacteria, depending on the situation there. So the accumulation of pus is referred to as purulent. That is the proper term. Okay, purulent means there's a lot of pus in there. Okay, it is not pussy. I'll leave you to figure out why it's not that. My wife had a nurse notate that in the chart. She had to go grab it. She's like, don't write that. Okay. It's purulent. The growth factors, these are going to stimulate the tissue to repair and to rebuild itself. So fibroblasts, smooth muscle, they can repair, they can grow. They can reconstruct the tissue. Now, that being said, they can't always reconstruct it properly. Sometimes they put collagen because they can't replace the epithelium appropriately. So what would that be? If you put collagen instead of the appropriate epithelium. No one's going to take a stab in the dark here? If you put more collagen than the original epithelium, like you get a wound and you put collagen instead of epithelial cells. What is it? It could be keratinized, but like a scar. Leslie got it right. A scar. That's all scar is. It's replaced with excess collagen or with collagen instead of the original tissue. And then you may have seen, especially like African American population and Middle Easterners too, they get them. They get keloids. Keloids is just an overproduction of collagen. It's just too much. The body goes out of control and does it. So sometimes once someone is forms a keloid, they are at high risk of forming more. Just that overproduction of collagen during repair. That's all that is. There are you can inject steroids and I forget what else into it and reduce them sometimes. But they are at high risk, if they go for surgery or something, that they form wild keloids, pierce their ears, stuff like that. And then vasoconstrictors, we got to stop that blood flow. And then lastly, with the platelets, they must aggregate. They must stick to each other. And the drug is Xarelto. That's the one I was trying to think of. I'm sure you've seen it all over TV. The beauty of Xarelto is you don't have to come in for blood work continuously versus like Coumadin or warfarin. You may have heard of that. Vascular spasm, so that's the constriction. That is the tightening due to serotonin. The serotonin is coming from platelets. We stop the loss of very important fluid inside of us, blood. Okay. All right, so we should have prostacyclin on our vessels. Prostacyclin stops the sticking. It's the Teflon. If you disrupt the prostacyclin and collagen is exposed, platelets will stick to it. If they stick to it, they degranulate. There's that serotonin, ADP, thromboxane A2. There's the vasoconstriction. There's more platelets attraction and more platelet aggregation. So if you've ever had surgery or like a tooth pulled, they always tell you do not take aspirin, do not take Motrin, Advil, Aleve, because all of these inhibit these guys. They give you Tylenol. They give you painkillers mated with Tylenol. So when you look at like your Norco and all that stuff, it's hydrocodone or oxycodone with acetaminophen, Tylenol, because it does not encourage bleeding. That's why we give them together. Also, we give them together because there's synergy of the medication, meaning the amount of pain relief from acetaminophen is like here, the amount of pain relief from hydrocodone is here, but you put the two together, pain relief is way up here. The two working together inhibit pain much greater than one by itself. That's why they're mated. That being said, they have broken apart more recently, like you can prescribe hydrocodone alone. The reason they were doing that, you're maxing out on the Tylenol. Patient can only have 4 grams of acetaminophen per day within a 24-hour period. So we start to give extra hydrocodone for pain relief in that setting. But yeah, that's why you're not supposed to take, like, a woman on her menstrual cycle should never take aspirin or Aleve or ibuprofen, Motrin, any of that, because it actually will increase bleeding. They should be taking Tylenol. Aspirin's like the worst too. So bad. So bad. All right. Coagulation. Okay. So we need to make fibrin to clot. We don't have fibrin floating around, otherwise we would just clot randomly. We don't want that. So we're going to see a cascade here like we saw in digestion. So we have prothrombin floating around in our bloodstream. Liver makes it. We're going to release prothrombinase. Prothrombinase will activate it to thrombin. This is a stepped cascade like we saw in digestive. Now thrombin will turn fibrinogen, which is also floating around, into fibrin. This is the active guy. Fibrin is active. That's what causes that webbing to form. That's the spider webbing that's active. After surgery, people are at incredibly high risk of developing clots. Because if you cut them here and they're not moving around, here can start this cascade to happen. So we used to have someone that worked here. She went in for gallstones. She had gallstones. And then like a day or two after surgery, she texts me in the morning and she's like, my leg is swollen and hot. I was like, take aspirin and call 911. Like, picked up the phone and called her. She texted me and I picked up the phone and called her. I was like, take aspirin, chew it, and call 911 because she has a DVT. So a DVT, a deep vein thrombosis, she had her gallbladder taken out and she developed a DVT. She's laying in bed, family's helping her, like, so she recovers. She's not moving. She's not moving the blood in her legs. She's had an injury, surgical injury. This cascade has started and she's not moving it around, so it built up a clot in her leg. And so the blood is accumulating behind the clot, below the clot. That's why it's swelling. That's why it's getting hot. Those are signs of a DVT, a deep vein thrombosis. She ended up being fine. She had to be on, I think they did put her on Xarelto, that drug specifically. She had to be on it for like 6 months while the clot degraded before it was safe. Okay. And we'll talk about those when we move into like blood vessels and stuff, but those clots will migrate to your lungs and get stuck in your lungs, and you cannot circulate blood through. You cannot oxygenate your blood. If they're really big, so that's pulmonary embolism. If they're really big, they're called saddle emboli. These people typically don't make it. My wife sees it all the time. They will code in the hospital. They suspect it's a big old PE or saddle embolus. It's sitting on the bifurcation of the blood vessels going into the lung, hence the saddle name. They will code them. They will come back and immediately recrash. Come back and immediately recrash. And typically they don't survive. And they're in the hospital. Imagine if you're at home. Right? Are they what? Being old is not necessarily a greater causation. Typically, obesity is a bigger risk. Being obese means typically more sedentary, like not moving, but post-surgery, post-massive infections, anything that could cause you to be sitting still and cause this cascade to function. Yeah, this will be pulmonary embolisms are wild. That being said, you can recover from them. You can clear them. They can be small ones. They can just take out a little piece. Okay. So yeah, birth control. Yeah, birth control can cause it. My wife's cousin had one in undergrad. She was on birth control and she was working as a scribe. So she's just standing all day. And because she was standing all day, she developed that stagnation in her legs, and she ended up having a DVT. She didn't go to a full pulmonary embolism. It didn't break loose, but it's very high risk of that happening. So it's pretty wild. Yeah, it is scary. It's something fun to deal with. My wife did have one elderly lady. I think she was like in her 80s, and she was out in like Arizona or something. Went to the hospital. They cleared her and sent her home, and she was having like a little bit of difficulty breathing and whatnot. She flew over here and then came in, and she had a big old DVT, and I think she ended up having a pulmonary embolism, survived, and walked out of the hospital. But my wife's seeing like 40-year-old males that have succumbed to pulmonary embolism. It doesn't pick and choose, right? It is a risk, all right? As far as extrinsic, intrinsic factors, these are two different pathways that can cause the clotting cascade to happen. Okay? So intrinsic for us, we just learn it's from damaged blood vessels. Extrinsic is the tissue triggering it. Okay? And it's really what they're talking about is these pathways here. We don't go into detail in them. But you can find patients, when you go further on, especially in like pharmacology and stuff, you do talk about this because patients can be deficient in different categories. They can produce too much. So if they're deficient, they're at increased risk of bleeding. Some of the drugs inhibit different points on here. Monitoring those points is important because if we overshoot, the risk of bleed is there. We undershoot, the risk of clotting is there. So that's why, like blood draws on patients are crucial. People usually don't know, it's a blood draw. They just want to look at some stuff. No, we could be looking at these different factors and going from there. There are people that naturally have deficiencies in these factors. So like hemophilia, for example, they bleed. You just bump them, and that's enough for them to bleed. I had a student that had hemophilia. I can't remember if he was like in his late 20s, I want to say early 30s. He had already had either a shoulder replacement or knee replacement because bumped it, blood got into the joint, destroys the joint over time, and he was due for the other one to be replaced as well. Hemophilia is pretty rare, but you do come across it from time to time. Von Willebrand's is another one. I just had a student last semester. Her and her daughter both had von Willebrand's. So they had bleeding disorders. They just bleed easily. So she told me she was diagnosed off her menstrual cycle. That's how they figured it out. Her menstrual cycle would just be excessively heavy, long. Her daughter, same way. Doctor went down the rabbit hole of testing them, and sure enough, they had von Willebrand. So they had to get injections periodically to help control the bleeding. All right. This is a real image of fibrin. See how it's like a webbing? That's active. Everything sticks to it and it forms clot. Solid. So say you have a clot. How do you break it down? We got to reverse it. We have to be able to reverse it. So we go backwards. We have to activate plasminogen into plasmin. So here's where we use TPA, tissue plasminogen activator. That plasmin can take fibrin and turn it back into the zymogen, into fibrinogen. It reverses it. TPA is a drug that we have in the hospital setting. TPA is an expensive drug. So they'll mix it, the pharmacist mixes it bedside. So during those crazy crashing patient, they suspect, saddle embolism, something like that, or pulmonary embolisms. They will mix it bedside and give it to the patient. It will dissolve the clot very rapidly. What's the risk? What's the risk of giving that medication to someone? Give something that breaks down clots very rapidly. Is there a risk? Is it safe? Can we just give it to anyone? Bleeding out. Bleeding out. So when you get stroke patients that come in, they say there's about a 4-hour window to save the brain tissue. They will scan them immediately and see if it's a hemorrhagic stroke, it's bleeding, they've ruptured a vessel and it's losing pressure and bleeding, or it's a clot. If it's a clot, give them TPA, we can clear it, potentially no brain damage. The sooner, the better. So you get someone that's acting kind of funny all of a sudden, they complain of slurred speech, droopy face, can't lift the arm, get them to a hospital ASAP. Don't go to urgent care. Don't call your doctor. Go to the hospital, okay? They may be having a stroke. Giving them TPA could save brain function. TPA is expensive, like I mentioned. I think my wife said it's somewhere around $40,000 per dose. Life-saving medication, though. The company that produces it wants people to use it to the point where if my wife mixes it and they don't inject it, they send it back to the company and they send them a brand new one. No one gets charged. It's such a life-saving medication. Right? So make sure you guys learn these 2 cascades. You're clear in the direction that they're going, okay, what they're doing. We produce it, yeah. We produce it naturally. Anytime, when you talk about wound healing, eventually you need to reverse that clot. Once we've replaced the tissue, we need to break it down to replace the tissue fully, so we reverse it. But it takes time. It's not rapid. It's not like a medication that we're giving. All right. Heparin. So heparin is typically fast acting. We give patients heparin very frequently, before surgery, because once again, we may start this whole cascade of them developing fibrin. So we give heparin, fast acting. Vitamin K antagonist. This is warfarin or Coumadin. That's rat poison. That's actually how they discovered it. Rat poison. We still use it today. If you've ever seen those black boxes around buildings, that has Coumadin in it or warfarin. It makes them bleed out. We overdose them. See, when you give a patient Coumadin or warfarin, you have to monitor INR. INR is the international rate for dosing, and it's between a certain point. If they are between that certain point, we are anticoagulating appropriately. They go too low, they clot. They go too high, they bleed out. These patients have to do blood work. I believe it's every 2 weeks, if memory serves right. It's a pain. It's a pain for the patient to go, do blood work, redose, all this. I did have a patient one time. I was looking at his chart. He's on Coumadin, and I cannot find blood work. So I go to my preceptor. I'm like, what the heck? Where's this guy's blood work? I don't see blood work for 6 months. Something wild like that. And he's like, call him now and find out why I'm writing him Coumadin and I haven't seen blood work. Apparently my preceptor had a brain fart. Okay. Called the guy and the guy's like, oh yeah, I have a home tester. So he's a really trusted patient. He has something where he can sample his blood and measure his INR, and then he would transmit it to the doctor, and the doctor would dose off of that. And after I told my doctor, my preceptor, he's like, "Oh yeah, I remember that guy. Yeah." He just had like a panic attack. So Xarelto is the new drug that's really replacing this. Xarelto, when you put a patient on it, I think they have to test it's every 3 or 4 months. So patient compliance is much easier. It's better for the patient, especially when you get into like elderly patients, people that don't drive, stuff like that. It's great for them in that situation. Um, and then TPA, like we talked about, that's given in emergency situations. There is a myriad of anticoagulation drugs out there. They all function differently. They all have benefits, cons, just depends on the patient. Risk factor for all of them, bleeding. So like these patients have to be educated on like tripping. The most minor trip can kill them. So my wife, like, she'll do patient educations and she always goes over like rugs. People don't think about it like rugs in your house. You catch the edge of it, you trip, right? They hit their head, they fall, and it's not even necessarily hit their head. When they fall and they stop suddenly, that jerking could be enough to rip vessels in the skull, and they can have brain bleeds. Um, so she always educates patients on this. Read patients' charts before you go to talk to the patient. Always read all of the charts, or at least sufficiently far back, right? And you got a patient that's been coming to you for 3 years. You only need to read like the past year. My wife didn't read the patient's chart. Walked in to talk to a patient, is educating him on fall risk. Patient's like, I don't need to worry about that. She's like, no, sir, you need to. Like, this is important. Like, you're going to be on this medication. It's really important. He's like, no, I really don't need to worry about it. She's like, sir, this is important. He pulls back the covers. He's a double amputee. The guy's wheelchair bound. And my wife's talking to him about fall risk. Read the patient's chart. Okay. He can still fall, right? He can fall out of his chairs. But what she was talking about, like rugs and stuff. It's like, come on, read the patient's chart. Okay. Uh, it's good times. But yeah, you hear about it all the time. All the time. Right? Especially elderly people, even if they're not on an anticoagulant, that risk increases. The vessels become more fragile, and so there increased risk of that happening. Right? Um, so preventing inappropriate clotting, prostacyclin, that Teflon on your vessels, dilution, hydration of patients is important. If you're dehydrated, the blood is viscous and at higher risk of clotting naturally. So hydration is important. And then the anticoagulants, like we talked about, right? Our body produces antithrombin. That's normal. Heparin, we produce heparin. Basophil mast cells, when they degranulate, there's heparin there. So we produce our own. So hemophilia, that's what we were talking about, typically seen in males. There's a very famous family. It was like what, Alexander the Great, I believe, the Tsar. Is that Alexander the Great? It was the Tsar of Russia. Very famous family because they were so inbred. They all had hemophilia. They just bleed out, and it doesn't take much. There are variations of it, but you will run into it. I've seen a few cases now. Hematomas. It is blood that is leaving the vessel and trapped in the tissue. You get hematomas anywhere. You may have, if you've ever crushed your finger in a door, that's a hematoma where it turns black under it, purple, red, black. That's blood under there. Typically, bruises are technically hematomas. When patients get elderly, like I mentioned, that is common because their blood vessels are weakened, the capillaries. So, like back of their hands, you always see it's like kind of purplish. Those are hematomas, and they're great identifiers for like elderly abuse. You start seeing odd bruising, that can be a sign. Same thing with young children. So like shaken baby syndrome, stuff like that. Those are technically hematomas. You see it also when people have, smack their head, stuff like that. They get brain bleeds. Those are hematomas. Okay. Had a guy I knew, used to go racing with him. He was out at Road Atlanta. He had a cage in his car, wearing a helmet. One of the turns, he lost control, smacked the wall. When he smacked the wall, his head hit the cage. He's fine. Doesn't want to go to the hospital. After a bit, started to feel nauseous. Took him to the hospital. He had a subdural hematoma and ended up passing away from it. Fell asleep. Eventually died. Right? Within the same day, roughly 2 days. Happened to Dr. Casey's father-in-law, just like last year. Door of the or trunk of the car is what they suspect opened, knocked him over. He hit his head. He hit the wrong button or something. So the automatic. My wife's childhood friend skiing hit his head, hit his head. Told his roommate, "I don't feel so good. I'm gonna go lay down for a while." Didn't wake up. He was like 24 or 23, something like that when that happened. Sonny and Bono, Sonny, I don't know, whichever one died. One of the JFKs, or the Kennedys, not the JFKs. Typically in the hospital setting, they try and drain it. Either they can put a port in and drain it, or we can give medications to drain it. So like mannitol. Mannitol is a very aggressive diuretic and pull fluid off. You have to get the swelling off the brain. The brain will crush itself and stop functioning.
But it takes time from the time you hit your head until you die.
Yeah, usually it could be hours, depending on the severity of the bleed, to like a day or two. And then there's risk factors. Is it worth it to do surgery or not? I remember Dr. Casey saying, like, in his father-in-law's situation, he had, I believe, a little bit of dementia already, and he was like 90. It's like, is it worth doing surgery? You got to weigh it there. But yeah, it's pretty wild. But yeah, it does happen. It doesn't take much. Thrombosis. So this is that clot. So we were talking about like deep vein thrombosis. There is a clot forming in the vessel. It is not moving. Thrombosis is a clot stuck in the vessel. If it decides to move, it's an embolus now. Emboli are portions that are moving, or the entire clot has broken free and is moving. It's going to get stuck at the next smallest point. So when you see these in the veins, because veins are big, blood doesn't move that fast in it. They're low pressure. They rely typically on muscles to milk them and move them. So that's where we're going to see clots, typically. Okay? Majority of clots are in veins. Well, when you talk about in your leg and the veins going up, they become bigger and bigger and bigger till you get to the heart. We're going to inferior vena cava into the heart. We pass through the heart, and then we go smaller, 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 coming out of the heart and into the lungs. So they get stuck in the lungs typically. You can have arterial emboli or thrombi and emboli, but typically these are seen like in patients with AFib. In AFib, because of the atria of the heart just fibrillating, it's going too fast, not functioning properly, there is stagnation in that blood, and that's how they can end up typically with an arterial embolus. Okay. Hey, we're done with blood. Let me look at heart real quick. How many days do we have to cover heart? The schedule. We have 2.5 days. Let's just cover a couple slides. Okay. All right. So, heart. Really, the entire purpose of the heart is to circulate blood. It's a closed loop system, meaning what comes into the heart is what goes out of the heart, is what comes into the heart, is what goes out of the heart. We shouldn't be losing volume of blood, and we should be able to replenish volume of blood if it is lost. How do we lose volume of blood? Injury, menstruation, sweating, because we're losing fluid. we should be able to replenish it. Now, if it's too fast, that's a problem. Okay, we must be able to have proper blood pressure. That's what allows for proper perfusion of the tissue to pass that nutrition to the cells. If the cells do not have appropriate nutrition, O2 and glucose, essentially, they will die. They cannot undergo cellular respiration. They will not generate ATP. They cannot have proper cell function. They die. If the cells die randomly like this, that's necrosis. Neighboring cells will die. It destroys general tissue. How long does it take for cells to die? Depends on the tissue. Depending on the oxygen demand. You talk about like the heart, seconds. It doesn't take much. So like in heart attacks, it doesn't take much. Okay. Kidneys, very rapid. Brain, very rapid. Skin, it's not so bad. Okay. The perfusion rate is less. So it really depends on the organ. Location of the heart, we'll see it's wedged in its own compartment. That's the mediastinum between the lungs. You can see it here. And then we can see in the X-ray here, the heart. Okay. That's aorta up here. So it's going to rotate around. That's what we're seeing. The heart sits angled and rotated. Okay. So when we listen to the heart, we listen to different areas. We're listening on where the blood is going. So sometimes, you'll listen under the arm here. You're listening for like mitral valve that we'll talk about. You're listening over here for the aortic valve. So it just depends on what you're trying to listen to, but you're really listening to direction of blood. Where the blood is going, the sound goes. Apex and base. Apex is point. So the apex is down, sitting on the diaphragm. Base is where all the vessels are coming in and out of at the top. So as far as where it's sitting, like we mentioned, between the two pleural cavities, so between the lungs, anterior right ventricle, he's kind of rotated. Left border, left ventricle. Right border, right atrium. Okay. He's rotated around. The three layers of the heart: pericardium, myocardium, endocardium. Peri would be like if we open up someone's chest and we looked at their heart, you're looking at pericardium. It's an outside, fibrous. Myocardium is the actual muscle. That's the one that's doing the work. That's what's making the heart beat. Endocardium would be if we opened up the heart and looked inside the heart and touched the inside wall, that's endocardium. That's what the blood is touching. So blood is touching endocardium. Myocardium is doing the work. That's the muscle. And then pericardium is if we opened up your chest and looked at it. That'd be pericardium. So pericardium, two layers that we look at: fibrous and serous, just like in the digestive tract. We saw parietal and visceral, same thing here. Okay, but now we change to pericardium. Right? So parietal, that is what is the more outer layer, and then visceral, that's what's touching the heart directly. Here he's got the fibrous pericardium pulled back. Okay, and then we see that shininess. That would be the visceral pericardium there. So fibrous is for like holding it, anchoring it in place. All right, so under the serous, we see parietal and visceral. Parietal is that outer fibrous layer. Visceral, that is the inside stuck to the heart, shiny layer, you can't peel it back. We see there is fluid between the two, serous fluid. That serous fluid stops friction, so there's not damage. So that's the pericardial cavity where that serous fluid would be housed. So pericarditis. Pericarditis means inflammation of that pericardium. There's all kinds of reasons. It's not necessarily just infection that is a causation. But for example, I had a friend that had a sore throat and then developed an autoimmune response and had pericarditis. Put him in the hospital. It's extremely painful. Typically, when you listen to these patients' hearts, you hear like a constant shh because it's rubbing because of the inflammation. Okay? So we can see pericarditis in that situation. Cardiac tamponade, typically this is seen post-MI. Person has had a heart attack, those cells die, the heart wall dies, and then it actually blows out. It rips. It hasn't switched over to scar tissue yet, so the first like 2 weeks after an MI are the most dangerous in reality. They can go into what's called VFib, not good, or they can have free wall rupture and develop cardiac tamponade. The other time you see this is like stab wounds. You can see cardiac tamponade there, or like Steve Irwin. Remember that guy? Crikey, no, the guy that always like jumped on gators and stuff, and he got stabbed with the barbs from a what's that, stingray? Well, had he left it in, he would be alive. When he ripped it out, he created a free wall rupture. The barbs are kind of like arrow hooks. And so when he ripped the tissue, ripped his heart open, and created cardiac tamponade. The problem with that is as the blood encases the heart, it starts to compress it, squeeze it. Every time the heart goes to beat, it's meeting resistance. Every time it goes in to beat, it shrinks, more blood gets out. When it goes to relax, it can't. So the amount that the heart can pump decreases and decreases and decreases. So what they do in that is they actually typically stick a needle right into the chest and draw the fluid out, reduce blood pressure, stuff like that. If they need to go in there and surgically repair even. It's pretty wild. So yeah, endocardium, that's the inside of the heart. Endocardium is a coating. So we see like the valves inside the heart are coated with it, and we can see infection of that or inflammation. So endocarditis. Endocarditis, you'll see a lot of left-sided endocarditis with IV drug use. This is why when you get like blood work, blood drawn, you wipe it down with alcohol. There's bacteria on you. If they just go straight and inject, the bacteria now will go through your vein and go into your heart, and typically on, I said left side, should be right side, sorry. Right side valve infection or endocarditis. Very common with IV drug use because they're not sterilizing, they're reusing needles between each other, stuff like that. You also see what's called sterile endocarditis or aseptic endocarditis in lupus. Women that develop lupus or in strep throat. Strep throat can develop it as well. They can develop a sterile or aseptic endocarditis. Their own immune system attacks the valves, destroys it. They can need a valve replacement. Typically we use pig valve, or we can use a mechanical valve. What's wild is with mechanical valves, they actually like cause hemolytic anemia. As the red blood cells come across it, they lyse. A buddy of mine, his mom, just like 2 weeks ago, she was put in the hospital for congestive heart failure. She had a previous valve replacement. She needed more valve replacements. She survived so far. She's doing well. Hope she continues to do well, but they did valve replacements. So the problem, or I think they did pick valve in her case. Those are better. They don't cause the hemolytic anemia, but the mechanical valves, because how stiff they are, is literally the red blood cells hit them, they lyse. Did I tell you guys when my preceptor told me to go listen to someone with a mechanical valve? When we talk about hemolytic anemia? No? Okay. So, preceptor one day, he's like, oh, I want you to go listen to this patient's heart. I was like, okay. He's like, leave your stethoscope. I'm like, what? He's like, just go without your stethoscope. So I go in there and she's like, oh, you're the students here to listen to my heart? I was like, yeah, but I don't have a stethoscope. She's like, it's fine, just stand next to me. And literally stand next to her, and all you hear is like tick, 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 tick. She had mechanical valves. You literally could just hear it standing next to her. I didn't know whether to run or chest. When you hear a person ticking, you get a little a little concerned, right? But yeah, pretty wild. She had mechanical valves, so you'll see quite a bit of endocarditis. The others, the root sorus, poor dental hygiene. They get rotted teeth, and it enters into the vessels there, and they cause endocarditis. So good dental hygiene is important. I actually know someone that died because of that. Poor dental hygiene. Went to the hospital. They missed it because the symptoms usually are like, just very vague. And then he showed up like 2 days later. It was really bad. Ended up dying from it. Sometimes they have some cool features like Janeway lesions. The bacteria will break off that's infecting the heart, and then it gets stuck in the capillaries of like their fingertips and their like foot pads, their toe pads, and you'll see these little black dots in here. They're Janeway lesions, is what it's called. It's pretty wild, but yeah. You got to give them IV antibiotics. It's a long process. They can recover. It's just not easy. Typically end up with a valve replacement. All right, we'll cut it there. Any questions? If there's no questions, I will see y'all Wednesday or in lab later today. See ya.